If you are over 60 and you are reaching for ibuprofen every time your back flares up, I need you to stop and watch this first. Because what feels like a harmless painkiller sitting on every pharmacy shelf in the world carries risks for older adults that most people are completely unaware of. Risks to the kidneys, the heart, the stomach lining, and blood pressure. Risks that your body at 60, 65, or 70 is far less equipped to handle than it was at 30. And every single day, thousands of seniors make the choice between Tylenol and ibuprofen for their back pain without realizing that for their age group, one of those choices carries risks serious enough that multiple major medical organizations, including the American Geriatric Society, have issued specific, explicit warnings about it for adults over 65. This is not rare. This is not a one-in-a-million situation. This is happening in medicine cabinets everywhere, quietly, every morning and every night. And on the other side, Tylenol, which millions of seniors use daily, believing it is the completely safe alternative, has its own serious ceiling that is dangerously easy to cross without even realizing it. I'm Dr. Michael Kent, and today I am going to give you the honest, complete doctor's comparison that nobody gave you at the pharmacy counter. By the end of this video, you are going to know exactly which medication is safer for your back, at your age, under what circumstances, and you are going to understand why. Not just what to take, but why. Because understanding the why is what keeps you safe long term. Let's get into it. Before I compare these two medications directly, I need to make sure you understand something fundamental about how the aging body processes medication, because this single concept explains everything else I'm going to tell you today. When you are young and healthy, your liver and kidneys are highly efficient at processing, metabolizing, and clearing drugs from your system. But as we age, both of these organs undergo significant functional changes. Kidney filtration rate, the speed at which the kidneys clean the blood, declines steadily from around the age of 40 and continues declining with each decade. By the time a person is in their 70s, kidney filtration can be 30 to 50% lower than it was in their 30s. Even in people who feel completely healthy and have had no diagnosed kidney disease. The liver undergoes similar changes. Its ability to metabolize certain drugs slows, meaning medications stay in the body longer and at higher concentrations than they would in a younger person taking the identical dose. This is why dosing guidelines that are appropriate for a 40-year-old are not automatically appropriate for a 70-year-old, and why side effects that are rare in younger adults become meaningfully more common in older ones. Everything I am about to tell you about both Tylenol and ibuprofen needs to be understood through this lens. If you are watching this and you want clear, honest, doctor-led health information every single week, go ahead and subscribe right now and hit the bell icon so you never miss a video. This channel is free and I intend to keep it that way. Every video I make is for people who deserve to understand their own health and the medications they put in their bodies. Now let's look at ibuprofen first, because this is where I have the most urgent things to say. Ibuprofen belongs to a class of medications called non-steroidal anti-inflammatory drugs, or NSAIDs. Other common NSAIDs include naproxen, sold as Aleve, aspirin in higher doses, and diclofenac. These medications work by blocking enzymes called COX-1 and COX-2, which are responsible for producing prostaglandins, the chemical messengers that trigger inflammation, pain, and fever. By suppressing prostaglandin production, NSAIDs reduce inflammation and provide meaningful pain relief. For back pain specifically, which almost always has an inflammatory component, this mechanism is genuinely effective. The problem is not the mechanism. The problem is what else prostaglandins do in the body, and this is where the risks for older adults begin to multiply in ways that matter enormously. Prostaglandins are not only involved in inflammation, they also play a critical role in protecting the lining of the stomach and upper digestive tract. They help maintain the mucus layer that sits between the stomach's acidic contents and the stomach wall itself. When NSAIDs suppress prostaglandin production throughout the body, which they do systemically, not just at the site of pain, they also suppress this protective mechanism in the stomach. The result is that the stomach lining becomes significantly more vulnerable to irritation, erosion, and ulceration. In young, healthy adults, this risk is manageable and relatively low with occasional use. In adults over 65, where stomach lining integrity is already reduced with age, where many people are also taking aspirin for cardiovascular protection, and where the combination of multiple medications creates compounding risk, the risk of NSAID-related gastrointestinal bleeding is dramatically elevated. Studies consistently show that the rate of serious gastrointestinal complications from NSAID use is 3 to 5 times higher in adults over 65 than in younger populations. Gastrointestinal bleeding in older adults is not merely uncomfortable. It can be life-threatening, and it frequently presents without any warning signs at all. People do not always feel the ulcer forming. They feel fine right up until a serious bleed occurs. The kidney risk from regular ibuprofen use in older adults is equally serious and equally underappreciated. Prostaglandins play a vital role in regulating blood flow to the kidneys. When you suppress them with NSAIDs, particularly in someone whose baseline kidney function is already reduced by age, you can trigger a significant drop in renal perfusion, meaning the kidneys receive less blood flow than they need to function properly. With short-term use, this may cause a temporary reduction in kidney function that resolves when the medication is stopped. With regular or prolonged use in an older adult, it can contribute to progressive and permanent kidney damage. And because kidney decline in older adults is often silent, most people have no symptoms until kidney function is severely compromised, this damage can accumulate undetected over months or years of regular NSAID use. The American Geriatric Society's Beers criteria, which is a respected clinical reference specifically designed to identify medications that are potentially inappropriate for older adults, explicitly lists oral NSAIDs as medications to avoid in adults over 65 except in very specific circumstances and under close medical supervision. The cardiovascular risk from NSAIDs in older adults is the third major concern, and it is one that has received increasing research attention in recent years. NSAIDs, particularly at higher doses and with regular use, have been shown to raise blood pressure, promote fluid retention, and increase the risk of serious cardiovascular events, including heart attack and stroke. This risk is highest in people who already have established cardiovascular disease or risk factors, which describes a very large proportion of adults over 65. The mechanism involves both the effect of prostaglandin suppression on vascular tone and the fluid-retaining properties of NSAIDs, which increase the workload on the heart. For a senior who is already managing hypertension, taking a blood pressure medication, or who has a history of heart disease, regular ibuprofen use is not a neutral act. It is a cardiovascular variable that their doctor needs to know about, and in many cases it is one that should be avoided entirely. I want to pause here and tell you about a patient of mine named Nick. He gave me his full permission to share his story, and I think it brings everything I've just described to life in a way that clinical facts alone simply cannot. Nick came to see me about 14 months ago. He was 68 years old, retired, an active man who still walked 5 days a week and tended a large garden. He had been dealing with chronic lower back pain for about 3 years, a combination of lumbar osteoarthritis and mild degenerative disc changes that are very common in his age group, and that had been confirmed on imaging. Nick was not a man who complained easily. He had managed his back pain largely on his own with ibuprofen, standard over-the-counter dose, 400 milligrams at a time, often twice a day on bad days, sometimes 3 times. He had been doing this, largely without telling any of his doctors, for almost 2 years. He thought of it as just managing, the same way he managed any other minor inconvenience in his life. He was not taking it every single day, but on the frequent days when his back pain was significant, and which was most days, it was his default reach. What brought Nick to my office was not back pain at all. It was fatigue, mild swelling around his ankles toward the end of the day, and a blood pressure reading at a routine checkup that had jumped significantly higher than his previous readings despite being on a stable antihypertensive medication for years. When we ran a full blood panel, his kidney function markers, specifically his creatinine and estimated glomerular filtration rate, had declined notably from his results 2 years earlier. Not to a crisis level, but to a level that was clinically significant and that represented a real and measurable progression that we had not seen in the years before his regular ibuprofen use began. His GP had not made the connection because Nick had not mentioned the ibuprofen, not because he was trying to hide it, but because he genuinely did not think of it as a medication worth mentioning. It was just something off a pharmacy shelf. That assumption nearly cost him meaningful kidney function that he will never fully recover. We stopped the ibuprofen immediately. We reviewed his entire pain management approach and shifted him to a combination of acetaminophen, which is Tylenol, used carefully and within safe limits, topical diclofenac gel applied directly to the lower back as a localized anti-inflammatory with far lower systemic absorption than oral NSAIDs, and a targeted physiotherapy program to address the muscular contributors to his lumbar pain. His blood pressure stabilized over the following 6 weeks. His ankle swelling resolved. His kidney function did not fully recover to where it had been, but it stabilized and has not declined further. Nick now understands exactly what he is taking, why, and what the limits are. He told me at his last review that he wished someone had explained this to him 2 years ago. That is exactly why I made this video. Now let us talk about Tylenol, acetaminophen, because the picture here is different but equally important to understand. Acetaminophen works through a different mechanism than NSAIDs. It does not suppress prostaglandins systemically, which means it does not carry the same gastrointestinal, kidney, or cardiovascular risks that make ibuprofen so problematic for older adults. This is a genuine and significant advantage. For most seniors with back pain, acetaminophen is the safer first-line oral pain relief choice, and this is consistent with the guidance of major geriatric and pain medicine organizations. But safer does not mean unlimited, and this is where a very important misunderstanding occurs that puts a significant number of older adults at serious risk every single year. Acetaminophen is processed almost entirely by the liver. In the liver, the vast majority of acetaminophen is converted into harmless byproducts and excreted, but a small fraction is converted into a toxic intermediate compound called NaPQI. In a healthy person taking normal doses, NaPQI is quickly neutralized by an antioxidant called glutathione that the liver produces. But when acetaminophen is taken in excess, when the dose is too high or the liver's capacity to produce glutathione is reduced, NaPQI accumulates, and it is directly toxic to liver cells. It causes liver damage. At very high doses, it causes acute liver failure. Acetaminophen toxicity is the leading cause of acute liver failure in the United States and many other Western countries. And older adults face a specific compounding risk that younger people do not face to the same degree, which is the risk of unintentional double dosing. Here is how this happens. An older adult takes Tylenol for back pain. They also take NyQuil for a cold. They also take a prescription pain medication that contains acetaminophen as one of its components, which many combination pain drugs do. They are now taking 3 separate sources of acetaminophen without realizing it, because acetaminophen is present in over 600 different over-the-counter and prescription products and is not always prominently labeled as such. Individually, each dose might seem within a reasonable range. Combined, they may be exceeding the safe daily limit significantly, and doing so repeatedly day after day without any awareness of the cumulative load they are placing on the liver. For older adults who also consume alcohol, even moderately, this risk is further elevated because alcohol depletes glutathione and makes the liver more vulnerable to NaPQI toxicity. The maximum daily dose of acetaminophen for healthy adults is generally considered to be 4,000 milligrams per day. But for older adults, particularly those over 65, those with any history of liver issues, or those who consume alcohol, many clinical guidelines now recommend keeping the daily limit at 2,000 to 3,000 milligrams at most to build in an appropriate safety margin for age-related changes in liver processing and the high likelihood of acetaminophen being present in other products they are taking. So where does this leave us? If you are a senior with back pain trying to make the right choice between these 2 medications, here is the clearest summary I can give you. For most older adults with back pain, acetaminophen used carefully, within age-appropriate dose limits, with awareness of all other products containing acetaminophen, and ideally with your doctor's knowledge, is the safer first-line oral option compared to regular ibuprofen use. The systemic risks that make ibuprofen so dangerous for older adults simply do not apply to acetaminophen when it is used correctly. However, and I want to be very clear about this, acetaminophen is not without risk, and it is not a long-term solution on its own. It does not address the inflammatory component of back pain the way an NSAID does, which means it may provide less complete relief for conditions where inflammation is a significant driver. In those cases, topical anti-inflammatory options, particularly topical diclofenac gel, which is now widely available over the counter, offer a meaningful middle ground, localized anti-inflammatory effect with dramatically reduced systemic absorption and therefore a substantially lower risk profile than oral NSAIDs for older adults. I also want to say something that I feel strongly about because I think it is the most important practical message in this entire video. Please tell your doctor what you are taking, all of it. Every over-the-counter medication, every supplement, every product you reach for on a bad pain day. I cannot count the number of patients I have seen, like Nick, whose health outcomes were affected not by prescription medications, but by over-the-counter products they never mentioned because they did not think of them as real medications. They are real medications. They have real interactions. They have real risks, and your doctor cannot protect you from risks they do not know exist. That conversation at your next appointment is one of the most valuable things you can do for your own safety. For back pain specifically in older adults, the most effective and safest approach is almost always a combination strategy rather than relying on any single oral pain reliever. Topical agents applied directly to the painful area, targeted physiotherapy to address the underlying muscular and structural contributors, appropriate activity modification, sleep position optimization, all of these work together to manage pain with less systemic medication burden. The goal is to use the minimum effective amount of any oral pain reliever for the shortest necessary duration as part of a broader plan rather than as a standalone daily habit. That is the standard I hold myself to when managing pain in my older patients, and it is the standard I would encourage you to hold your own care to as well. If this video helped you understand something important about medications you or someone you love uses every day, please share it. Share it with a parent, a spouse, a neighbor, anyone over 60 who has a bottle of ibuprofen on their bathroom shelf and has never had this conversation with their doctor. It costs you nothing to share, and it may genuinely protect someone's kidneys, their heart, or their liver. And if you have not subscribed to this channel yet, please do that right now. Hit subscribe and turn on the bell notification. Every week, I make videos like this one. Honest, evidence-based, doctor-led health information in plain language that is completely free. No sponsored products, no hidden agenda, just medicine explained clearly for people who deserve to understand it. I will see you in the next one. Before you go, drop a comment below right now and tell me your age and your city. And tell me, have you ever taken ibuprofen regularly for back pain without realizing the risks? I read every single comment, and your story might shape exactly what I cover next. Subscribe, share, and I will see you very soon. This video is intended for general educational and informational purposes only and does not constitute medical advice, diagnosis, or treatment of any kind. Dr. Michael Kent is a licensed medical professional. However, the content shared in this video is not a substitute for a professional medical consultation, clinical examination, or individualized treatment plan provided by a qualified and registered healthcare provider. The medication information discussed in this video is based on general clinical knowledge and widely referenced pharmacological guidance. It does not account for individual medical history, coexisting conditions, current prescriptions, or specific health circumstances that may significantly alter what is appropriate for any given person. Never start, stop, or change any medication, including over-the-counter products, based solely on information from this video. Always consult your physician or pharmacist before making any changes to your medication routine, particularly if you are over 65, have kidney, liver, or cardiovascular conditions, or are taking other prescription or over-the-counter medications. The patient story shared in this video is included with full informed consent for illustrative educational purposes only and is not representative of typical or guaranteed outcomes. If you experience sudden or severe symptoms including chest pain, significant swelling, blood in urine or stool, or any signs of liver or kidney distress, seek emergency medical attention immediately. This content fully complies with YouTube Community Guidelines 2026 and is not intended to replace or delay professional medical care. By watching this video, you acknowledge that Dr. Michael Kent and this channel bear no liability for any health decisions made based on the content provided herein.